you want.
Yeah. But medications, often rather than adding medications, I think about de-prescribing or taking away medications. Medications should really, a cardiologist I used to work with up in Portland shared this kind of concept of medications with me, and I use it all of the time. And I try and share it with as many people as I can. And I think it fits well into the 4Ms model. A medication should help you live longer, help you live better, decrease symptoms, or a medication should kind of decrease events, avoid things like, exacerbations of your heart failure or your chronic obstructive pulmonary disease. And if medications aren't kind of meeting one of those three criteria, you really need to think about, is that medication right for you?
Right, especially if it's adding more problems than it's resolving, I suppose, and we see that a lot in the mental health world, especially psychotropic medications. How often do you see it in your world where somebody comes in, maybe you meet them for the first time and they've got all these medicines on board, and you have to almost do a medication audit of sorts to restart or get to a different baseline, and then how hard is that? With somebody who's been used to taking something for a really long time that just maybe doesn't benefit them anymore?
Sure, I think that's a great question. And so, yeah, the use of many medications is a common geriatric syndrome. Polypharmacy is kind of often how we describe that. And our goal as geriatricians is kind of finding inappropriate polypharmacy, again, where medications aren't meeting one of those three criteria. And so often we do medication reviews. And like I said, I work with a pharmacist. And that's a real reason I work with a pharmacist, is because I need to kind of lean on their expertise to kind of make sure we're making the best decisions for that person. In approaching a person that you're concerned about inappropriate polypharmacy, it really takes a systematic approach in developing a relationship with them. The first thing you always want to do is kind of find out what their understanding of that medication is. Because that's always the best place to start, because the worst thing you can kind of do is put your foot in the mouth and make some assumptions. Often there's multiple treatment plans and lots of ways to kind of get to a certain way. And our goal as providers is just to find out how they got there, to see kind of what the current assessment is of that medication. Is it helping? Is it not helping with what we thought it was going to help with? And then if it is accomplishing those goals, is there a better way to accomplish those goals, or is this the way we want to continue? And then if it's not accomplishing those goals, how can we safely get off this medication and find a way to accomplish that goal? And sometimes it's not with the medication. Sometimes there's other avenues, such as therapies or even cognitive behavioral therapy, utilizing other specialists that could be useful.
You bring up talk therapy there. How often is that used in your realm with the older population? And do you find people nowadays are a little more amenable to it because of the emergence of the popularity of mental illness treatment and mental health care? Or is there still like this generational resistance to going into counseling?
Yeah, so I guess the first thing with that question is I imagine somebody's looked at that question and maybe published some information. I'm not familiar with that. I know in my practice, anecdotally, so just kind of my opinion, one of the people I work with is the social worker. She's also a psychotherapist, and so utilize her all of the time. In that setting, almost always offer it if I feel like any of the, if I think it'll be useful, or we think it'll be useful rather. And so all of the time, as far as people being open to it, I think there's a big bias that I deal with as a provider. I think people are often more apt to say yes to me than to no, especially if it's my recommendation. And so I think, I think most people tell me yes from my experiences. A handful of people tell me no, but when I recommend it, most people end up saying yes.
Do they follow through?
Almost every time I'm working.
Do they follow through? Or is it like yes in the office?
So in the office, it's harder for me to know. I've had lots of recent job changes, and so I've just recently had to kind of be referring more people to psychotherapy, and so haven't had so I can't really answer that question. In my kind of other consult job that I have right now, people are following through.
That's good to hear. I think for a long time there was a little bit more of a resistance from the older population, but I know for us at Zephyr, we're starting to see a little bit more of an uptick in older people attending counseling than we did 5 years ago when we founded. I think that there's I don't know what the change is, but it's almost like people are realizing that it's okay to examine one's long held beliefs, and, especially if they're in misery or pain, and it's like, well, I kind of want to get out of this pain, and maybe I need to take a look at some habits. That's really, that's cool. What are list your jobs? Cause it sounds like you're actively practicing, you got this team. Where does that take place? And then what else do you do?
Yep. So right now, I do outpatient geriatric consults to the UNR Meds Sanford Center of Aging.
Okay.
And so we do consults where we work on that interdisciplinary team that I mentioned with the social worker and a pharmacist. We also have a medical assistant that works with us, and then we also have to have a team of learners like a geriatric fellow or a pharmacy resident or another type of resident working with us. And essentially we see patients in about an hour and a half visit where we do an interdisciplinary assessment, ask a lot of questions, then make some recommendations at the end of the visit, and share those recommendations with their primary care provider or the referring provider for them to discuss with the patient and their family. We cover a lot of things, have lots of access to community resources, and again, I'm the MD on some of the assessments. I work with 2 other MDs on the assessments as well. We kind of rotate the schedule. Often, I think we always add an important part to the visit, but sometimes we're not the main part. Sometimes a lot of those other financial or social things are really what's affecting somebody's health the most. And we spend most of the time talking about that.
It's a really comprehensive system, and I was very surprised to hear you say it's an hour and a half long appointment. That really is very rare, I think, these days, or at least people's perception of it is rare, is that it's rare. How, I guess I'm struggling to phrase this question the right way. I don't know that many people have the advantage of going to a doctor's office and getting that type of wraparound care. I know it's different at the university settings. There's more resources and so forth. How do we make that happen more often? How do we get people together on a team approach in this current climate where there's insurance billing concerns and that kind of thing?
I think if you ask for it, people will make it. I think that's I think people need to know that this is an option, and if this is the option that people want, you need to let your providers know, and talk to them. I'm a really kind of grassroots kind of guy with that type of massive change that you're talking about, Jake. I think that there's a fee-for-service system built into our insurance company, and it's really tough to, when we get those the 3 of us kind of experts in there, at times that's a medical degree, a pharmacy. A doctoral pharmacy degree, and then at times we also have a PhD social worker in there. And so it's a bunch of really, really smart people in a room that you have access to, and then their knowledge and kind of the area of expertise. And so it takes a lot of extra support for that, and understanding the value and the potential for cost savings and high value care. I think as we focus on it, I think focusing on high value care that's offering you the service that you're looking for is should be the focus of the grassroots effort. If again, an hour and a half visit with these 3 disciplines is something that people want.
So really what we need to do is just start doing it. I need to reach out to we're in a provider shortage now in Nevada, and almost everybody has 3 or 4 jobs, but I need to reach out to people like you and other professionals in different disciplines and just say, hey, would you mind spending some time 1 day a week or something at Zephyr Wellness to hang out, and as people want to come through, we can staff or something. I just literally don't know how that would work, as busy as everybody is. But it's got to start there. It's got to start, like you said, grassroots is a great way to describe it. Somebody just has to start doing it instead of waiting for the system to change, because it won't. We'll have to be the ones that change it. Go ahead.
And as we've done this, there's been more tools that our leadership has been able to utilize to increase our ability to fund and pay for this. And so it's really about being creative about that too, and communicating with, like, hey, I'm doing it this way. We're successful for all of these reasons, and potentially they would be more open to funding a new method of care. Essentially coming up with a new service that you're providing for a new fee.
Right.
One thing that we utilize a lot is chronic care management, and so the ability to kind of offer telephone visits in between visits to kind of make sure that you understand the complexities of all your providers, the things that were said in your last visit, be able to kind of have an easier access to that kind of specialty care network of your physician or your pharmacist, whoever you need to talk to kind of answer those questions. And so that's something that everybody has access to as far as being able to enroll people in chronic care management through Medicare. And so lots of patients, maybe that would be one thing to do, start asking like, hey, can you refer me to chronic care management? I think it might be helpful.
Yeah. One of the fights you mentioned, Medicare, is that federally, marriage and family therapists and licensed professional counselors cannot bill Medicare. And that's been ongoing since like 2000. And so that's a frustration that needs to be solved as well. But I never heard of chronic care management before. Is that accessible to anybody? How's that work?
Yeah, so if you have Medicare, then you have the ability to access chronic care management. As far as if your primary care provider has a chronic care management program, you'll have to ask them to see if they do. There's a couple of I think Sanford Center might be kind of unique in this respect, where we don't really take over the primary care aspect, but can still offer the chronic care management portion. But I know lots of other primary care provider clinics offer chronic care management, and I would always say you want to stick with your general community of providers, especially if you trust them and have a relationship. And so would encourage you to ask your providers first. But if that's not an option, the Sanford Center does have a chronic care management program that we're enrolling patients in.
Share a little bit about the Sanford Center for Aging. I don't know that a lot of people know that it even exists. It's been around for a long time, but also what it does.
Yeah, so I'll do my best to describe it. There's the director of the Sanford. He's Peter Reed. He's a PhD in education, and so he's been the director of the Sanford Center for longer than I've been at the university. And so and the Sanford Center has been around even longer. Initially came from an endowment years ago, just to kind of help make sure that the University of Nevada, Reno always has a place where geriatric education and geriatric care can happen. So it's really a great thing. The Sanford Center has grown into lots of different things. I think the things that are most notable to me, as far as kind of a community standpoint, is their wellness programs that they have, diabetes prevention programs, some exercise programs. Some of these things are in flux with the current pandemic and COVID-19, but in general, those are lots of community resources that people can participate in to kind of improve their general health. And so those are just kind of a couple with the diabetes prevention program, fall prevention classes. I think they have some pain education classes as well. And there's also a big research component and big educational component essentially for the community and the state too. The Sanford Center was the recipient, and Peter Reed was the recipient of a 5-year, $3.2 million grant, the Geriatric Workforce Enhancement Program grant, to essentially develop an educational model and increase geriatric care services for the state. And so Peter's, I think, come up with a great plan to improve education throughout the state. And he's kind of rolling out a plan, including lots of different healthcare systems and lots of different healthcare centers. And so if you're a healthcare center out there and you're interested, let us know. Just feel free to reach out to us. It won't be anything right away, but I think it's always good to talk about. So we want to hear more about that.
That's awesome. That's super encouraging. Thanks for sharing the invitation. Share a little bit about COVID-19, if you would. You work with the most vulnerable population, I guess, as most people have determined that, and people with pulmonary issues and underlying health concerns. But the elderly population is really been hit the hardest, and they come with the highest level of risk. How's that affected you and your client base, and what advice and feedback do you have today? I know it's changing daily, but
I think I would echo a lot of what our health experts have said. I think the biggest thing is to always act like you're infected, whether you're young or an elder or whoever you are, and always kind of respect other people. Wearing a mask is about protecting you from other people, and so that's what elders really need from us right now, is us to think about them and have our actions kind of be more to benefit them than they are ourselves if we're younger. And so that would be the main thing that I think about is lots of the things that we're doing aren't necessarily for your own good all the time, but for the general good of us all, and that will help you. And especially with our elders, because they're all of our stories, they're all of our knowledge, they're all of our experience. And we've lost a lot of that over the last 4 months. We lose a lot of that all the time, but it's been accelerated, and it's really unfortunate.